So John Lasala from WashU will come up and give the first point, atherectomy is a must, and then Arthur Reitman will give IVL is good enough in the majority.
Okay. Thank you, RJ. As for most debates, the truth really lies somewhere in between. Cardiac calcium, I mean, most of my practice is referred in. Most of that is because it's complex, obviously, and most of that is because it's heavily calcified. There are lots of different things that produce calcium, vascular smooth muscle cells that drive a lot of it, its localization, where it's identified, how much of it is a key component. We know unequivocally that both acutely the results are worse with heavy calcification, and even over the span, if you do a landmark analysis over the first year, it's much worse. We have to deal with it. What does it really come down to as far as whether IVL or atherectomy should be done on these cases that we clearly need some sort of calcium modification? If you break down this slide, what it really comes down to, can I cross it or not? If I can cross it with an IVL catheter, then I'm good to go. If I can't, I've got to do something to modify it before I get to the next stage of either ballooning it or using IVL on top of that. So this is a field without much data at all. It's all going to be anecdotal, and it all comes down to simplicity of having something that will it work or not? Can you cross or can you not? Looking at the degrees of calcification of severe on the left, moderate on the middle, mild on the right, we usually think that if it's double-walled, it's going to be something we need to deal with. We can go ahead and develop a calcium score based on the circumferential calcium, the length of the calcium, the diameter, the nodularity. OCT gives us the calcium thickness as well, which is very helpful, in addition to the arc and length. We know that somewhere is a cut point of around 2, where it actually, our results in terms of our ability to expand the stent, which will translate into results, it changes dramatically as we get up with a higher calcium score. So we're not going to really look at the different types of things that we have out there, whether you prefer rotation and orbital. I have my own algorithm for that. The more dense, the more calcium, the length of it, the more I'm likely to do rotablator. If I've got room for this to spin a crown, then I go to orbital. Laser doesn't really ablate calcium, at least not at the levels we're using it, but it can fracture it. And of course, shockwave fractures things very well. So one has to be really facile with all if you're going to be able to do a real type of chip analysis. If you look at a quick one here, this is a relatively simple case that we're going to look at, but it does go down the algorithm as to how best to choose your technology. Many people would not do much of anything other than to balloon and stent this, but they would be disappointed because the degree of calcium here is very, very high. If you look at it on OCT, we've got a 360 arc. We've got maximal thickness of 1.3, so it gets us another point on a length that's almost 10. So you got a total of 4 points, even though it's not very impressive as far as an individual lesion goes. So the calcium score is high. And here's the important dichotomy. Can you cross or can you not cross? And in this particular situation, it did cross. We can develop all of the sizing by measuring, certainly with OCT or with IVUS. But because of the fact that we've gotten all the lengths, we can size this appropriately. The balloon crosses. We can go ahead and get good expansion. In fact, in a balloon-only day, this would be a phenomenal result. We would probably just leave it alone. But we go on and we can take a look at the fracturing. It's fractured, so now we can go ahead and stent. We've got our measurements. We can go ahead and get that result. And what we end up is a very, very nice result with fully expanded stents reaching those optimal requirements that Dr. Moreno just talked about, 90% expansion or greater. So that's one way in which we can certainly use IVL in imaging. But where is atherectomy really mandatory? Here's a couple cases of mine that early occurred over the span of just a couple months. There's no way IVL is going to get down there. There's no way a balloon's going to get down here. This is really non-crossable territory. So we've got to go ahead and use a rotablator, in this case a 125. Then we can modify it significantly. There's the results after the rotablator, and here's after stenting. This is where atherectomy is truly mandatory. This is where the discussion as far as the debate stops. You have to have something to be able to get through this degree of calcification. This one's not so profound. This one looked like to the operator that initially approached it, I can get a balloon across this really easy. Though a 1.5 balloon didn't even get close to this. So if I can't get a 1.5 balloon, I'm not going to get a shockwave balloon through this. I've got to go ahead. In this case, it was done with orbital atherectomy. So not to discriminate too much between the atherectomy devices. But you get a nice channel after that, and you balloon, and you've got it done. And the third case example that I'll go with is really even more profound. It's a CTO of a right coronary artery, patient very symptomatic. Difficult to engage, no wires will go through. Here's the collateral, as you can see, coming to the right corner. No good, no retrograde options. Got a wire through. Even though we're kind of cattywampus there trying to get through, the wire gets through, and you think that you're, going to be in good shape here. Here's the wire getting through, but nothing else tracks. No microcatheters, no 1 millimeter balloons, no nothing. Well, I can't do much atherectomy-wise if all I've got is a 014 wire, except what? I can use a laser. He just said you can't really ablate with a laser. But you can get it to fracture and try to get something else down. So in this particular case, a bunch of laser pulses, still no luck. Went back again, more laser, 38 different laser trains finally to get through. It's a new indoor record. And now you can get a microcatheter down. And now you can go ahead and swap out for a rotablator wire. And at 180,000 RPM, follow up multiple balloons, including shockwave, you get a nice result like this. So it's not a debate. It's really, they're synergistic, they're very complementary, and it's hard to rely on one without the other. The trends at atherectomy are clear, they're going up. We're doing more significant disease. That is not going to be significantly impacted by IVL. It only gives us another tool to approach this type of disease. The fractures may not be as profound in people who have less than 180 degrees. That's seen in this particular model on the left here. And in just looking at various registries here, this is the PAS, which is looking at CAD3, which was used for IVL. You basically have a lot of things going on with IVL and combinations. So in conclusion, respect to calcium. It is the primary component of acute and long-term elevated MACE levels. The prevalence is increasing as a result of age, obesity, diabetes, et cetera. You have to have good abilities with all the preparatory tools to allow for delivery expansion and to lower your complication rates. It's always better to modify before you stent. The atherectomy is growing. It's not diminishing with the advent of IVL. The two work in combination nicely in affecting dense calcification, and you have a calcium score for imaging to help you with making these decisions. The whole crux is you can't shockwave what you can't cross. And if you can't get your IVUS across, you certainly won't get your shockwave balloon. Thank you very much.